just talking to the patient. Sometimes when we do medication reconciliation, I'll ask the patients what color their maintenance inhaler is. And if they have no idea what their inhaler looks like, you know that they're not using it like they should.
This is one area where I find it incredibly frustrating that we don't have lower priced medications available to help people do the basic life function of breathing comfortably.
On today's episode, we'll listen in as our expert panel discusses answers to your big questions about treatment of asthma and COPD. Our guest today is Dr. Lori Wilkin from the University of Illinois Chicago College of Pharmacy. You'll also hear practical advice from Dr. Stephen Carrick from the USC School of Medicine Greenville, Dr. Andrea Darby-Stewart from the University of Arizona College of Medicine Phoenix, and Dr. Craig Williams from the Oregon Health and Science University.
And now, the CE information.
This podcast offers continuing education credit for pharmacists, physicians, and nurses. For the purposes of disclosure, Dr. Wilkin reports a relevant financial relationship as a consultant for AstraZeneca, Simpson Healthcare, and Optum Rx. The other speakers you'll hear have nothing to disclose. All relevant financial relationships have been mitigated.
To start us off, Stephen, would you mind giving us a high-level overview of some of the similarities and differences between asthma and COPD?
So asthma and COPD, common lung conditions, I think in terms of overlap similarities, these are lung issues going to manifest themselves as shortness of breath, cough, wheezing for patients. They'll have some sort of exacerbation component to them where the symptoms will get worse, either triggered by allergies, infections, pollutants in the air. Asthma is unique, and then this is more of a supersensitive lung airway, reversible airway pathology, usually seen or starts earlier in life and strongly associated with things like allergies and also has genetic predispositions for it. While COPD is more of an irreversible airway obstruction, something that progressively declines over time, usually triggered by tobacco use is probably the most common thing, but there are other chemicals or environmental causes that may cause progressive lung decline over time and usually presents later in life, usually as adults.
That is a great overview. Thank you. And then another question that we had was goals. What goals are you aiming for when you're treating asthma and COPD? Andrea, would you mind tackling that one?
Sure. Much like anything else with our patients, we're really looking for alignment with what their goals are. Most people want to breathe a little bit more easily, not to have symptoms on a regular basis, to either have no limitations or improve their ability to exercise. And in the case of both asthma and COPD, to really improve their overnight sleep. We don't want them to have episodes of poor control in the middle of the night, since we know for all of us that sleep is such an important part of our health. So can my patient run if their children go to PE or participate in their team sports without any difficulties? That's great. For my older patients with COPD, are they able to play with their kids and their grandkids without having any significant limitations in terms of shortness of breath or difficulty? Can they do the things that they love to do, gardening, maybe not loving the chores, but able to do them without feeling substantial symptoms?
We did have a couple of questions come in about what are some of those clinical clues from patients where you suspect they may be overusing reliever meds and need an adjustment of their maintenance meds?
I'm happy to jump in. You do have to think differently about asthma versus COPD, which is kind of a theme we have going. So it's less clear for COPD. To kind of Andrea's point, the goal is really kind of making the patient as functional as we can. And to Stephen's initial kind of overview, it's a chronic condition that doesn't ever fully resolve, whereas the goal in asthma is really to kind of normalize lung function and normalize the patient's functionality. So in the setting of asthma, ideally, you're using almost no reliever. So, but I think of it more as like days per week in asthma. That's how the guidelines kind of outline is thinking about your asthma control in your patient. If it's more than 2 days a week they use, and it's not ideal control, and we should think about other controllers. For COPD, it's kind of less clear, because if they're on good maintenance therapy and they're having frequent at-home exacerbations that don't require any interventions or step up in care, it's not real clear there's a number of uses per day of their albuterol ipratropium that there's necessarily a problem as long as they're managing it. But I think we all have a number in mind, like for me, more than 10 uses a day of any reliever is a problematic number, but there's not a clear number from the studies. And to Andrew's point, it goes somewhat to the goals you have with the individual patient.
Excellent. Lori, would you want to chime in on anything you see in practice?
Yeah, for our patients that when we check their refill history and we see that they're not using their medication, if you're lucky enough to have pheno detector there in the clinic, that will help you know that they're not using their inhaled corticosteroids, but that's pretty selective. And then just talking to the patient. Sometimes when we do medication reconciliation, I'll ask the patients what color their maintenance inhaler is. And if they have no idea what their inhaler looks like, you know that they're not using it like they should. So a lot of times they'll tell you they're struggling with using that maintenance inhaler.
That's a great tip. Thank you for sharing. So let's move along and dive into some of the specifics with asthma management. I was hoping, Craig, would you be able to give us a high-level overview of the different inhaled meds we use to treat asthma?
Yeah, the really high level overview is there are relievers and there are controllers, and pretty much everything you can kind of plug in under that. The relievers, then we can break down into short acting, and then as we'll talk about, kind of a short acting, long acting combo. But really, those are the two. A nice way to teach these medications is decide which side of the bucket you're on. One of the big differences between COPD and asthma is that controllers really work for asthma. So the guidelines are very quick to making sure you're using a controller and really minimizing reliever use. Whereas in COPD, it's really more kind of what combination of relievers works to make the patient's symptoms as minimal as possible.
Andrea, would you mind giving us an overview of the GINA guidelines and how you approach asthma treatment, starting with an adolescent or an adult?
Sure, absolutely. So the guidelines really do recommend that we have a clear understanding of how severe the patient's asthma is. Some patients will have intermittent exacerbations, and so they fall into our low step or steps 1 and 2, and they might use an as needed low dose inhaled corticosteroid formoterol combination. And this is a big change compared to what we used to do, which was give everybody an albuterol inhaler and say, give me a call if you're using it too frequently. These guidelines now recommend the use of as needed inhaled corticosteroid and that shorter acting formoterol. If we have patients who are having more frequent exacerbations or by spirometry qualify for step 3 or step 4, then they may need either low dose maintenance or medium dose maintenance with that inhaled corticosteroid and formoterol combination. So they'll be taking these medications on a daily basis. And then they can also use the exact same medication for their rescue inhaler. For people who are brand new to asthma, this is great. They get one inhaler, which is hopefully covered by their insurance appropriately, and they can carry that with them and also use it on a daily basis as a preventive. For patients who have not were in our prior type of coverage for this, sometimes it's a little bit more challenging to get them to give up that albuterol and trust that their maintenance inhaler can be used for rescue as well. And then once we get to patients who are in that step 5, where they're having more frequent exacerbations, their FEV1 to FVC ratio is significantly reduced, then they're going to be on a high dose combination. And we might actually add an antimuscarinic agent or even a biologic. And at that point, from my standpoint as a family physician, this is where I would get my pulmonary colleagues involved in the care of the patient.
Excellent. Thank you. And so to point out the differences with track 2, this is an alternative track in the guidelines. Would you mind just reviewing what the recommendation is if someone cannot be on one of the steroid short-acting beta agonist combos?
Yeah, absolutely. And again, that comes most of the time down to finances and availability, or, quite frankly, preference and people who are comfortable with a certain type of treatment. But what we do know is that we want all of our patients to be using an inhaled corticosteroid whenever they need to use their short-acting bronchodilator. And so for those patients who, again, have that rare exacerbation, we do ask them to use an inhaled corticosteroid along with that as needed short-acting bronchodilator, albuterol for most of our patients. So this is the more traditional approach that most of our listeners are probably familiar with.
Okay, thank you. And Lori, we specifically had a question come in about what's the role of Singulair and Montelukast.
I think that what we see with glucotrienes receptor antagonists is many years of comfort, but not a lot of efficacy. So when a medication is viewed as safe, then we see a lot of prescribing of it. And when it's an oral medication, it tends to be easier to take and use. And we see it's approved for a wide variety of age groups. So you see a lot of use of that. But in practice, I would say its efficacy is lacking unless somebody has allergy symptoms. Then I see the allergists tend to add it on, and it tends to help with allergies and asthma.
Yeah, if I can just add briefly, I will see in leukotriene antagonists that for patients having a lot of trouble with inhalers, what we find, and the guidelines kind of support that some people are responders and a lot of people are non-responders. So when you look at an average population, or we think about just, the last 50, 60 patients we saw, on average, they don't work very well. And we've always known at the population level, they don't work as well as steroids, but some people, they do seem to work well in. So we certainly haven't thrown them out, and we still keep them in mind. And the NIH has them a bit more favorably placed in their guidelines than does GINA, but they still remain in our armamentarium. But we should be prepared to stop them if they're not working, which is the case for a lot of people.
Yes, thank you. Andrea, how much is height really affected by inhaled steroid use, particularly in children? And should we worry about the inhaled steroids affecting height in kids?
The last time I looked, there was a slight reduction in height velocity in kids that were on chronic inhaled corticosteroids that was resolved as they hit adolescence or when they stopped the inhaled corticosteroids. But I would love it if Craig or Lori would chime in with the most recent updates.
Yeah, so that's basically still the case. And we'll probably never have any better data than we already have from an old study that did a pretty good job looking at this. And that was the case. So poorly controlled asthma has its own effects on everything in developing children. So we certainly use steroids if we need to, but it's fair that they are not quite as prominently placed in kids as they are in adults for that reason. But yeah, slightly slowed velocity during the time of use, but they seem to catch up later and does not affect their end height after puberty.
Thank you. We also had a subscriber ask, I noticed Primatene Mist was not in the guidance at all. Why? Should we ever recommend OTC Primatene Mist? I think some of our pharmacists are probably getting this question a lot since it's on the shelves in the pharmacies.
Yeah, we were shocked that it got put back on the shelf. Everybody was in an uproar. As you all know, it contains epinephrine, so it's not selective, and we can have cardiovascular side effects. But I was looking at the labeling of the Primatene Mist, and I really like how the inhaler is labeled as far as compared to our regular inhaler. It has actual instructions listed on the side of it.
Yeah, it's just a terrible drug, Sarah. It's an ultra short-acting albuterol. So we use it as when we're teaching the pharmacy students, say, if anyone brings this up to your counter, it's a great point to say, what are you using this for, and do you have a provider? Because it is out of the guidelines for a good reason, and ideally wouldn't even still be available. And there's a second product, I think asthmanephrine is the other branded name for it. But yeah, not a good therapy at all.
Super helpful for our listeners. Thank you. I'm going to jump us over to COPD treatment and answer some questions here. Stephen, would you mind giving us an overview of the different types of inhaled meds to treat COPD?
Yeah, I'd be happy to. And in terms of COPD treatment, I think as Craig alluded to, with similar overlap with asthma, there's long-acting and there's short-acting medications. We still have our short-acting bronchodilators, things like our albuterol. We also introduced this category of short-acting muscarinic antagonists, things like ipratropium that can help alleviate some of that bronchoconstriction that may be associated with COPD. We also still use our long-acting beta agonists, and then also the category of long-acting muscarinic antagonists, things like tiotropium, again, trying to just provide more prolonged relief of that bronchoconstriction and hopefully alleviate some of their symptoms. And our inhaled corticosteroids, although maybe not used as universally as in asthma, still in the right patient, right population, may have some anti-inflammatory effect that may help alleviate some of those symptoms and help our patients manage those symptoms with COPD. And these all come in various combination forms as well.
Thank you. And Lori, would you mind giving us an overview on how to treat COPD initially, just pointing out some of those differences from asthma.
Sure. I think the big point to remember with the COPD patients is the antimuscarinic component. So using that long-acting muscarinic antagonist, that's the big difference compared to using the inhaled corticosteroids in asthma. And when we're first starting out, if they're seen in general medicine or family medicine, they're probably not having a lot of symptoms yet, just starting to complain about it. So any of the bronchodilators would be an option, although the long acting are more convenient. But when they start to have more symptoms, that's when we're trying to combine the long acting muscarinic antagonist with the long acting beta agonist to get more bronchodilation. And that's when those combination products really are helpful. And then once the patient starts to have exacerbations, so we typically look for prednisone use in the past year if they've had 2 exacerbations or 2 prednisone bursts in the past year, or 1 hospitalization that was related to COPD. That's when we're really making sure that they're on combination therapy and then possibly adding on an inhaled corticosteroid to help decrease those exacerbations if they have higher eosinophils.
That leads us right into what's the role of inhaled steroids. Andrea, would you want to tackle that one?
Absolutely. This has changed just a tiny bit with the last gold revision. And basically, if a patient has a history of being hospitalized for COPD, or they've had 2 or more exacerbations in the last year on max meds. So that means the patient's been adherent to their meds, they've been taking them appropriately, you know that they're actually using the inhalers appropriately. Or if their blood eosinophils are more than 300, then we should be adding an inhaled corticosteroid to their LAMA and LABA. If the patient has more than 100 eosinophils, you can consider adding that, particularly if they're at higher risk for exacerbation. But we know that inhaled corticosteroids may increase the risk for pneumonia. So if they have a repeated bacterial pneumonia, the history of a mycobacterial infection, then we would want to avoid use of inhaled corticosteroids in these patients. So there's a lot of if-thens that occur when you're thinking about adding an inhaled corticosteroid to your COPD patient.
If I could just jump in real quickly, I know the guidelines have had the eosinophils listed here for checking for inhaled corticosteroid use for the past couple of updates. I'm still seeing, even in the pulmonary clinic, our pulmonologists just now getting up to speed with checking the eosinophils and not knowing really, what the cutoff point is. I feel like if a patient is having exacerbations that are related to a hospitalization, or if they have a really low FEV1, that they will lean towards using an inhaled corticosteroid. But of course, if the patient has pneumonia from being on triple therapy, then they'll start to step back away from it.
Thank you for sharing that. Can you clarify for our listeners, Lori, when it's okay to use LABA monotherapy?
Yeah, the full guidelines still list LABAs as an option for our patients, and they really haven't shown they have an increased cardiovascular concern in our COPD patients. But I'll tell you from practice, a lot of times there's confusion with whether the patient has pure COPD versus having a little bit of asthma component. And I see a fear from our doctors from using LABA alone, just because they don't want that downregulation of the receptors and the patient's not responding to a quick reliever. So the only time I see a LABA used alone, and other people jump in too, is when we can't get a LABA, or if something's not covered on their insurance, or if a patient had a side effect from a LAMA that they're still using a LABA.
Yeah, I'll add, Sarah, that if you can get a LAMA, there's really no reason to use a LABA ahead of it. But if it's definitely a COPD patient, it's absolutely safe. So it's in the guidelines still as an option. And those cardiovascular concerns just did not play out when kind of prospective studies were done. There was some early data doing a lot of retrospective mining of health systems. But it is safe, but generally llamas are preferred and might have a bit more persistence of benefit. Llamas might win by a nose in many patients, but it is safe if it is a COPD patient, very unlike asthma.
Thank you. Another audience question. It seems like most patients with asthma should have a steroid, but not with COPD. So, how do you treat patients with both COPD and asthma? And Lori, you kind of commented on this, but could you expand on this a bit?
If a patient has asthma, even if they have asthma and COPD, they should be on an inhaled corticosteroid. It might be a lower dose inhaled corticosteroid, but oftentimes these patients are more severe and we're using triple therapy for them. I always tell the students if the patient has asthma, you want to make sure that they're on an inhaled corticosteroid.
And I'll also add, Sarah, that we've debated this topic in the literature for a while, and that goes by different acronyms, this combined COPD asthma condition. It's fortunately probably fairly uncommon. I mean, your classic asthmatic 25-year-old with allergies to dog danders, very different than your classic COPD patient, 65 years old, with a history of smoking. But there's no question patients with mild asthma can age into developing COPD. And yeah, it's probably more that some COPD has a very reversible asthmatic-like component that benefits from steroids. And as we talked about, the gold guidelines are trying to figure out for like 30 years who really benefits from steroids. It just has COPD. And we used to say it's this asthmatic component COPD patient. And so, but fortunately in our practice, usually they're pretty distinct patients. But yeah, if there's asthma present, steroids much more favored. And you really need to be on a steroid for your asthma.
Thank you for clarifying. So I want to move us along to talk about correct use of inhalers, since about 70 to 80% of patients do not use their inhaler correctly. So what are some common mistakes you see in practice, Andrea, when you are talking with your patients with asthma or COPD?
Well, I still have patients popping the entire inhaler in their mouth, which is, probably not the best when they're using their short acting inhaler, or they don't put it far enough in their mouth. If they're using that technique correctly, they're actually just putting it right up against their teeth. That's not great. They're taking a quick inhale versus a kind of a nice long deep inhale. They're not shaking the inhaler. They have no idea how to look at the number of counts on the back of the inhaler, which is a really important thing, particularly for our patients with asthma, when we know that they do need to have that rescue inhaler immediately available if they have a severe exacerbation. And a couple of my teenage patients let me know that when they're in bed, they just kind of lay over on their side and take a puff off the inhaler while they're laying down at night if they have an exacerbation then. So just really trying to help. We've got some great handouts. We do some directed training with patients for appropriate inhaler use, and hopefully that improves everything for them.
Thank you. And so, in addition to providing handouts, what are some other things we can do to help patients use their inhalers correctly, Lori? What are things you do in practice?
I have a lot of fun going into the rooms and counseling patients with inhalers. I get to see all those fun things that they're doing incorrectly too. One thing that I've used over the years is a standardized checklist. I saw somebody doing this for a clinical study, but then when I started using it in practice, I found that it was much streamlined, a lot better. Also, the teach back method. So, making sure that the patients are able to teach back what I just taught them is really important, because I oftentimes would think, oh, yeah, they understand. And then when they teach back, you can see the things that they still didn't grasp. And the third thing that I like to use is videos. So I will use the videos from the manufacturer's website, but I also use the useinhaler.com website, American Lung Association. A lot of different organizations have really good videos, and people respond well, especially if it's in another language or it has written instructions and sound effects while they're using it. It seems to go along with the teaching and the checklist really well.
I'll just add briefly, Sarah, that MDIs are really difficult to use well. DPIs, I think, are easier to use as intended. So, and I think manufacturers are picking up on this. A lot more dry powder devices coming out. And actually, I probably prefer those for most patients over an MDI. An MDI really should be used with a spacer to really get optimal delivery. And that's just to ask someone to carry a spacer with them. Maybe Andrew can give a spacer, you have it at the bedside of your teenage patient, maybe but using a spacer makes it so much easier. But that's just the compliance with those is just terrible. So, but dry powder inhalers, you get rid of all that issue of trying to time your inhalation with the aerosolation of the medicine. You just give that strong inhalation on the device. So I really like the dry powder options when they're available.
Thank you. Stephen, do you have any comments on tailoring inhalers to different patient populations?
No, I kind of go along with what the group has said. I mean, really assessing for adherence, the best inhaler is the one they're used on a regular basis. And I'll add too is there's still a lot of confusion about for patients and understanding which one is their inhaler and which one's their controller. I'll see it all the time in clinical practice, using a controller or using them for the other purpose. And so really providing that education and guidance and making sure they understand the indications and timing for when to use certain inhalers.
Good point. We had a couple of questions about nebulizers. So are nebulizers more effective? What's the difference between nebs and inhalers? Lori, would you want to comment for our listeners on that question?
Sure. I think patients see the nebulizer used in the emergency room or the hospital, and they tend to think that the nebulizer is more effective, not realizing that the dosing that's in the inhalation solution is so much higher than that of a puff of the medication. But with COVID, I think we really went by the wayside and started using a lot more meter dose inhalers with spacers. So we did some training to get some of our patients away from using nebulizers so much. So it's not necessarily more effective. If somebody has trouble with technique, I think then it is a good option for patients to still have that option of using a nebulized medication if they're not able to use an inhaler correctly, or they have arthritis or something like that inhibits their use.
Yeah, I'll say, and generally many more adverse effects because the dose is so much higher and you get a much higher dose you swallow. And some of these drugs are fairly bioavailable, including albuterol. So nebulizers generally recommended when someone cannot use an inhaler device.
Thank you. We have a ton of questions coming in from the audience. A couple are coming in about beta blockers. So Craig, I was wondering if you could comment on this. To what extent can a beta blocker use impact patients with asthma or COPD? I know this question comes up quite a bit.
It does, yeah. Unfortunately, it comes up enough and for long enough time, we have pretty good data that we should avoid non-selective beta blockers. So classically, when I was in school, that was propranolol. These days, carvedilol is the one to keep in mind. So probably a bigger issue with our patients with asthma than with COPD. But if you have an obstructive lung disease, we should generally avoid non-selective beta blockers. And these days, that really is carvedilol in practice. So, but if you have a cardiac indication for beta blocker, a cardioselective agent is absolutely okay and will not worsen pulmonary outcomes. So it's a good question. It does come up a lot.
Thank you. We also have a question about the incidence of thrush with inhaled steroids. Lori, would you want to comment on how often you see that in practice?
Sure, and I just wanted to add to Craig's comments about the beta blockers too. Don't forget about the eye drops. That's something that I see a lot in our COPD patients with glaucoma. So making sure that they get switched off of something that's not going to cause problems with their breathing too with the eye drops. But the thrush, I see once in a while in our patients. They're not rinsing their mouth or they're not using a spacer. Sometimes we have to lower the dose of the inhaled corticosteroid or switch to a different agent. But yes, that could make somebody non-adherent because they don't want that thrush or that side effect.
Yeah, so it's really quite minimal with a spacer. If you use a spacer device, I really found you don't really need to rinse your mouth afterwards because it's just so little of it deposits in the oral pharynx. So really dependent on technique and patient use.
Lori, could you just briefly discuss what MART is? And if there is an increased incidence of thrush with MART, since you can use the inhaler a lot more often?
That's an interesting question. So, MART is maintenance and reliever therapy. It's when our patients are needing an inhaler on a daily basis. Usually, we use ICS formoterol as the maintenance, and it will be usually once or twice a day. And then they'll also use it as a reliever. So it's really nice if you're able to get enough of the inhaler covered for them to use for both maintenance and reliever. And then the rinsing of the mouth. Interesting on the studies, when they use ICS formoterol as a reliever, they didn't have the patients rinse their mouth in the studies, and they didn't see an increased risk of thrush. So I still tend to tell them to rinse and spit. I guess it's just stuck as part of my education point.
Thank you. Question for Andrea or Stephen. So, how do you handle calls from pharmacies when certain meds are not covered? And how do you switch between inhalers if needed?
Gosh, there's a few options that we have, and I think one thing that I've noticed over the past few years is that the EMRs can sometimes be a pretty helpful tool at the point of the patient care, at least acknowledging which medications, especially combined inhalers, may be covered by patient's insurance. So that's one thing that at least has evolved over the past several years. I think the second too is always just trying to go towards generic medications. Those tend to be at least the most affordable, and then some of the other prescribing practices of 30-day supply versus 90-day supply, and that may hopefully provide easier coverage for patients as well. Andrew, I don't know if you have any other suggestions too.
No, I think, as long as our EMRs are updated, that's helpful. The challenge, of course, is that a lot of these inhalers are not covered, not available by alternative means. And so talking with the pharmacist or asking my MA colleagues to ask the pharmacist what might be covered, knowing where the formulary is available online and doing a little bit of digging to see what I might have available as well are really just the ways that we can help mitigate this. This is one area where I find it incredibly frustrating that we don't have lower priced medications available to help people do the basic life function of breathing comfortably.
Yeah, what could be frustrating too is that they'll change suddenly too. So you have a patient really well controlled for a period of sometimes years, and maybe they switch on to Medicare or they switch insurances, and then they have to go back, and you almost feel like you're starting over again with a different inhaler, and there's now a cost barrier for them to, just have a better quality of life because of the disease process.
Every January.
Lori, do you have any tips from your clinics and how you help your patients afford their inhalers?
No, we do the exact same thing.
Okay.
It's a game of playing, switching around, and everybody gets frustrated.
I mean, maybe the only upside is, llamas are pretty interchangeable with other llamas and labas with other labas. But yeah, it's a frustrating whack-a-mole game to have to play on the provider side, and very frustrating for patients and very frustrating for pharmacists who have to deal with us on the front line too. But they can be your best friend to help figure out which one is the covered agent.
We hope you enjoyed and gained practical insights from listening into this discussion. Now that you've listened, pharmacists, physicians, and nurses can receive CE credit.